Greetings. It is almost 6:30. It is now 6:30. I'm delighted to welcome you to the second session of our Healthcare Roundtable, COVID-19, Healthcare and Beyond. My name is Emily Lynn Osborne, and I am the Interim Dean of the Graham School of Continuing Professional and Liberal Studies. I am also a professor in the Department of History here at the University of Chicago. Today, we are hearing from Dr. Ishia Beck and Dr. Daniel Johnson to consider COVID-19 from the perspective of community outreach and community healthcare. Before I introduce our presenters and my fellow moderator, Dr. Dorian Miller, a few words about the format of this discussion. This is a webinar. That means you are not able to use your microphone and your camera is turned off. We are recording this event so that we may post it online for people to watch at a later date. You are able to communicate with the moderators and ask questions of our speakers through the question and answer box at the bottom of your screen. We encourage you to do so. Our panelists will be taking questions from the audience periodically through the discussion, and we also reserve the last 25 minutes or so for Q&A. We will likely not be able to answer all of your questions, but when we do, we may read your name. You'll find the button to open the Q&A box at the bottom of the window. Additionally, we are providing live captioning for this roundtable. If you would like to be able to read the proceedings as they take place, please click on the CC button at the bottom of your screen. As I often say, the Graham School serves as the front door of the University of Chicago. It is a welcoming, accessible, open door. It is our mission to swing that door open to a wide audience of curious learners and engaged global citizens. Last week, we met with two doctors who offered a view of the pandemic from the perspective of the University of Chicago Hospital, and we learned about the protocols of COVID-19 treatment and vaccine distribution, among many other things. Today, we open Graham's doors with two doctors from the university who will talk about their work with underserved communities and the effects of the pandemic on children and Latino communities in the Chicago area. Next week, we gather again to delve into local and global effects of the pandemic. We will focus in particular on the effects of COVID-19 on Black communities and to issues of mental and spiritual health and well-being. And now to today's panelists. Dr. Ishia Beck is a primary care physician and health services expert who evaluates and implements interventions aimed at improving health among Latino communities. Much of her research has focused specifically on diabetes among Latinos and the barriers that hamper access to screening and treatment. This emphasis reflects Dr. Beck's wider interest in the social determinants of health and the experiences of ethnic and racial minorities in the healthcare system. Dr. Daniel Johnson is an expert in pediatric infectious diseases and in the care of HIV-infected children. He is deeply involved in community-based pediatric care in underserved areas, for which he has worked to improve access to quality health care. He is the founder and director of ECHO Chicago, which uses an asset-based approach and leverages existing resources to strengthen community services. His publications cover a range of topics, including HIV, infectious disease, health outcomes, and community medicine. My fellow moderator in this effort is Dr. Dorian Miller. She is a general internist who has been providing care to underserved minority populations for 30 years. In addition to her role as a primary care physician, she has a special interest in behavioral health. She has devoted herself to community-engaged research and practice that aims to improve health outcomes for residents on the South Side of Chicago. I am grateful and would like to thank Drs. Miller, Beck, and Johnson for joining us today. I also want to thank a few people behind the scenes who are helping to manage the technical aspects of this webinar and who you may encounter through the Q&A box. These fabulous, thoughtful, and talented people are Zoe Eisenman, Andriana Scaramella, Jan Watson, Natalie Watson, Nikki Yagoda, and Tina Dillon, who was our transcriber this evening. Many thanks. Dr. Miller, you have a few words you'd like to say?
Thank you so much, Dean Osborne, and welcome to the people who are participating in this webinar from not just the Chicago area, but from what I understand, both nationally and internationally. The University of Chicago Medicine is absolutely delighted to partner with the Graham School for Professional and Liberal Studies on this series, and we look forward to your questions and comments during what I think will be a very wide-ranging and also provocative discussion this evening. Our first speaker is Dr. Ishia Beck. Dr. Beck, would you like to get started with the first part of your presentation, please?
Yes, hi everyone. Thank you so much for this opportunity. I'd like to thank the organizers at the Graham School and also Dr. Miller for moderating today. So I'm Ishia Beck. I'm a primary care doctor. That's the first thing I do. I take care of patients, and that's in clinic. I have my own patients that I take care of. I work in urgent care. I round at the hospital with residents and medical students. So teaching is also my passion. In addition to that, I have a role at the Pritzker School of Medicine where I pretty much monitor the students who are doing community-based research over their 4 years and give them guidance, which is another important aspect of my work, is not only doing the research and taking care of patients, but also training the next generation of researchers and clinicians. Now, my major role at the university is as a health services researcher in Latino health disparities. And I will share some slides to sort of talk you through some of the work that I do and really why I do it. So I'll first start nationally. So we know that the Hispanic population is increasing, and here the trends are about 61 million people in the US are of Hispanic origin. And the projections are that by the year 2050, about 30% of the US population is going to be of Hispanic origin. Now, what does that mean for Chicago? In Chicago, most of the Hispanics, like 6-7%, are actually Mexican American. But then also we have actually one of the largest Mexican American populations in the country, like after Los Angeles, Houston, and some of the border states. But actually beyond the border states, we do have the largest Mexican American population in the US. And in terms of Latinos, they make up about 30% of the Chicago population. And I put this map up just to sort of show where the Latin population is in Chicago. And you'll see there's a concentration here in the southwest side and then the northwest side as well. And this doesn't show the suburbs, but there is an increasing number of Hispanic people who live out in the suburbs as well. Now, most of my research, and we're here sort of on the south side, right, in Hyde Park. Most of the work I've been doing has been in a little village, South Lawndale community, which is on the southwest side here. And there in the little village, 80% of the population is Mexican American, and many are low income and Spanish speaking and immigrants as well. So that's a population that I've been working with. Now, why is this population important? Well, as an internal medicine doctor, I'm very interested in chronic disease, right? That's a lot of what I see. That's a lot of what I treat. And diabetes is one of the chronic diseases that I see in many of my patients. And when we see here, we do see this disparity in who has diabetes. We do see a high level of high prevalence, let's say, among American Indian populations, also Black non-Hispanic, but then also in Hispanic populations, which is very high. And actually, the CDC put out numbers back in 2015 that like 19% of Mexican Americans in the US have diabetes. So very high rates of diabetes. So when we think about, well, when we're trying to manage our chronic illnesses, what's important? So some of these social determinants of health are very important. So the average Latino household only owns 80 cents for every dollar held by a non-Hispanic white household. Issues in the built environment, so violence, limited space for exercise, poor access to fresh food. So when we're counseling our patients on healthy eating and exercise, there are barriers to that in some communities. Language barriers also, so many US Latinos speak Spanish at home, which may translate over to the language that they want to receive their medical care in. And also access to care. So you need to have access to care. Medical care is one of the main tenets of taking care of diabetes. So still about 18% of US Latinos lack health insurance. Although I will say when we disaggregate the data, we do see differences. So this is from 2014, so it's been a while, but the US overall uninsurance rate is 14%. Among Hispanics overall is 25%. But you see, when we disaggregate and we actually look at foreign-born Hispanics who are non-citizens, that rate of uninsurance is 50%. And in Little Village, that's approximately what it is. I'll also talk about the economic hardship. So this is actually a score that the Rockefeller Institute has put together, and it has these 6 variables. And this is a slide from the University of Illinois, Chicago. And I have this circle here on the Little Village area, which we're seeing, has really high hardship scores. So unemployment in terms of education, income level, poverty, crowded housing. Although crowded housing to me is also a misnomer, it could just be multi-generational home, and then dependency. So the work that I do is to bring services to these communities in terms of diabetes education. So I use a community-based partnered research approach in working with patients who are actually in the community. So not having them come to the health center to get the diabetes education and support, but then partnering with churches, partnering with community health workers, community organizations to not only get out to the community and go to these churches that are trusted in the community, and also accessible to community members to receive diabetes education. And from that, I've also been working with community health centers across the Midwest in addressing different ways of providing diabetes care. And so we've been doing diabetes group visits where adults with diabetes come together, about 8 to 10 in a group, and within a 2-hour visit, they not only receive diabetes education, but they can also get a medical visit, refills, their flu shots, and some peer support as well. So most of my work has been in working with community health centers and churches and organizations to improve the care of Latinos with diabetes.
Dr. Begg, thank you so much for providing us with that background information about not only your practice, but also your interest. I think that it'll provide some very important level setting as we continue in our conversation. Our next speaker is Dr. Daniel Johnson, who is going to provide us with the same type of information around his work and later the importance and how it ties into issues around COVID-19. Dr. Johnson?
Great, thanks, Dr. Miller, and thanks to the organizers for inviting me to be here tonight. As Dr. Miller mentioned, my name is Daniel Johnson, and I'm a pediatric infectious disease specialist. So much of the work that I do at the university is divided up into really 3 categories. First is that I do take care of patients. And as the name implies, I take care of children who have complex infections. Anything from the challenges associated with taking care of bacteria that are resistant to antibiotics, and therefore the person overseeing their care needs my help to select an antibiotic, to taking care, of course, of patients with COVID and the complications that are associated with that, and concerns about what are the right approaches to the care of kids, something which we'll touch on tonight. But the other thing that I do with my time is to lead part of the Department of Pediatrics. I'm a vice chair in the department. I also work to lead 2 of the sections. One is called academic pediatrics, and the other one, quite naturally, is the pediatric infectious disease section. And then the third thing that I do with my time is work on scholarly pursuits. And one of those areas is intimately related to the Urban Health Initiative that actually Dr. Miller is an important part of. And there, the goal is to try and expand access to care, at least the part that I work on the most. And part of that effort, as you heard from Emily, is a project called ECHO Chicago. And ECHO stands for Extension for Community Health Outcomes. And what it does is build capacity in order to address issues of disparities in access to care. And the approach we take is an asset-based approach. And what asset are we making use of? Well, there's the amazing asset of primary care providers, physicians, nurse practitioners, physician assistants, but the whole professional group that works on primary care. So it also includes social workers, case managers, community health workers, and others who are working out in the community. And they have an amazing skill set that can be expanded. And that's what I mean by workforce development. We work with that group of individuals to be able to expand their skill set so that that way they can expand what they offer to patients and the people who come to them for their needs. And so we do that with an eye on addressing issues of disparity and access to care. And the way in which we think about this is that we set up a room very similar to what we're doing tonight, except with one major difference, which is that our goal is a high level of interaction with those providers, so that that way they can get their questions asked and answered. And we do this through a case-based recurring set of sessions. You can almost think of it as virtual rounding. Many of you have probably watched TV shows or have even yourselves been patients where you've seen where a group of providers come in and one of those providers presents you or the patient as a case, something that others need to hear about and then have an opportunity to learn from. And what we're doing is doing that virtually, where that primary care provider brings the information from that patient in a HIPAA-approved manner, a manner that allows us to not identify the patient. So patient health identifiers are held back, but the pertinent information of the case is presented. And then in an interaction through that other great asset, which is the academic specialist, there's a discussion that goes on. And that discussion leads to an exchange of information. And with that exchange of information, what we're able to do is ensure that patients may not need to be referred away from their primary care medical home. They can receive their care at the right place and at the right time, so that they don't have to move out of their community even to receive care, because we expand the ability of those primary care providers to deliver care. And those providers then acquire new knowledge, they're able to treat more patients, and they're able to expand their community of practice. And in this way, we're addressing issues of disparity in access to care, because many of the patients who are in those communities receiving care from those providers are underserved, in part because they're underinsured, in part because they may not have the means to move from one location to another. And so what we're doing as well then is building a community of care in order to reduce disparities, keep providers in that area who are then challenged even more so by the care needs of their patients. And we're able to keep the patients local. And in fact, we're even able then to help build the services that are in those communities. And by keeping patients local, they're able to improve access to care. They're able to spend their money in that community, so it improves the economic development of that community. And really, what we're after is a democratization of medical knowledge, so that that knowledge moves from the academic center out into the community at the speed of light, just like we're doing tonight. And what we do is teach best practices. We transfer knowledge using technology, so that way nobody has to move. And the end result is that we multiply the availability of services in the community and dramatically expand access to care. You don't have to take my word for that, because the providers themselves tell us that. We've done analyses that show that. And what we've been able to do with this kind of project is build access to care. Echo Chicago, my program, was the third such program to use this model for care. Now there are well over 400 such programs around the world doing exactly what I've just described. So with that, I'll stop sharing my screen and turn things back over to Dr. Miller.
Thank you so much, Dr. Johnson. And we'll come back to some of these issues around ECHO and how it's interfacing and really responding to the pandemic a little bit later. Dr. Beck, I'd like for you to talk a little bit about some of the effects of the COVID-19 pandemic on the Latinx community, please.
Yes, thank you. I'm going to show a couple more slides here. So I always feel that visuals are very helpful. So especially these maps. So here, the great thing about the Chicago Department of Public Health is that they're actually tracking a lot of data, and they have started, they started tracking actually back early in the pandemic, and they had these maps that are coming out weekly. So here we see, this is data through November. We weren't able to find the maps that are more recent, but I think this is really indicative of what's going on. So here again, we see this map of Chicago. The 60623 area is where most of my work is in Little Village, and you'll see dark blue. So that's accumulative deaths due to COVID. And when we look at the bar graph as well, we do find just really high rates of age-adjusted mortality rate in the Hispanic community compared to other race ethnicities and even overall in Chicago. The IDPH, Illinois Department of Public Health, is also tracking age of death, average age of death. And we do note, again, for Latinos, it's a little bit lower, although Hispanics in the US and in Chicago are a little bit younger. The average age, at least in the work that I have done in South Lawndale, is about 55, so a little bit younger. So again, we see high rates of death and mortality due to COVID. So in terms of test positivity, we see also, again, really high test positivity in this community, also in sort of this southwest side where is also heavily Hispanic in Chicago. Also, unfortunately, the rate of testing, again, this is through November, fairly low. So I think this points to we need to have more testing in these communities. And when we do test, the positivity is very high. So this just looks at, since the beginning of the pandemic, what's been happening to Hispanics, and we see the percent positivity has pretty much been higher than non-Hispanics. And in early March, April, you know, these rates, they seem very high, but just in working with my community advisory board in Little Village, there were testing sites there where 65% of tests done were coming back positive in the Hispanic community. Now that may mean that just the case rate is high, so many people are getting COVID. It could mean that people are only coming in and getting tested when they're ultimately like very, very sick. So it points to many other disparities potentially as well. So, you know, I talked about a lot of the social determinants of health and how it impacts diabetes and chronic care. But I actually think that, you know, a lot of the disparities that we're seeing now in terms of COVID, they build upon those in terms of language accessibility, access to care, even the neighborhoods people are living in, even transportation. One can even add in trust of the medical system, of healthcare providers. But in terms of COVID, I think it came also down to economics. So if you can't work from home, you're more likely to get exposed in some of these essential jobs, like, you know, working in transportation, working in food service, working at grocery stores. So a lot of these folks can't necessarily work from home, and also paid leave. So do they have access to stay home if they're not feeling sick? So I think these are really important social determinants of health that We've always known as physicians in the healthcare system that these are important in terms of people accessing care if their sugars are running high with their diabetes or if their blood pressure is running high. But I think with COVID, we're sort of seeing these disparities kind of being unearthed again. So I think I'll stop there. And really, in summary, high rates in the Hispanic community in Chicago, and we're seeing this nationally as well. High rates of mortality, low rates of testing, and just a lot of the social determinants of health that are impacting all this along the spectrum of from testing to hospitalizations to mortality.
Thanks, Dr. Begg. We've actually got a couple of questions that have come up in the chat. And so I'm going to start with you, Dr. Begg, for one, and then I'll shift over to Dr. Johnson. The question for Dr. Begg is, what's the main cause of mortality in the Hispanic communities that you've noticed in some of your work?
I think that it goes along with what we're seeing actually nationally, like cardiovascular disease, diabetes, cancer. There are some numbers where actually cardiovascular disease, sometimes in some Hispanic populations, it's like less of a cause of mortality, but the thought is that maybe because it's a younger population. But I think it's pretty much the same. It's just that when, like among Hispanics, you have diabetes, you're more likely to have a stroke or cardiac issues. Mm-hmm.
Thank you. And then Dr. Johnson, this is a question that goes back to your description of ECHO. The questioner says the ECHO program sounds like a brilliant means of delivering expert care in a cost-effective way. What metrics can you cite to demonstrate efficacy and outcomes?
That's a great question. Thank you for asking it. So we have published, as have other projects, and they really cover the wide range of outcomes that you would want to see. So first is the ability to do knowledge transfer. And that's been measured in terms of provider self-efficacy and their ability to be able to deliver care. And what we've been able to see is a significant rise in that. In fact, it's the only program for postgraduate medical education that's ever shown an increase in knowledge and self-efficacy for providers. So that's very reassuring. The second area is patient outcomes. And there's been comparisons depending on the disease process, but in hepatitis C, hypertension, just to name two, we've been able to show identical outcomes in terms of the success of care for patients, whether those patients were sent to a subspecialist or those patients received care through their primary care provider for the medical problem they had. We've also been able to look at this at a population level in terms of looking at the success of the care of patients, whether or not there were changes in outcomes, and whether or not there was a change in provider behavior as a result of the interventions. And once more, we've been able to show equivalency, and in fact, in some cases, actually improvement in the outcome of patients because the patients don't have to travel. And because the patients are receiving care locally, they're more likely to follow up. There's also evidence that because of some of the provider changes, that actually you're reaching a larger set of patients. And so the outcomes there show improvement. And then last but not least, our colleagues in Missouri did something that actually was quite remarkable. They looked at the outcomes in terms of cost for the patients. And they showed across their state millions of dollars of cost savings as a result of patients not having to be referred elsewhere. That reduced duplication of services, but maybe even more importantly, because of the timeliness of services, it showed a reduction in hospitalizations and a reduction in emergency room use. So on many levels, we've been able to show the outcomes. Thanks for the question.
Excellent, thank you. Dr. Begg, we have another question for you, and then after that, we're going to move into our discussion around vaccines. And this is actually a combination of a question and comment. Shouldn't diabetes education for needy Hispanics start during early childhood? The questioner says, I'm a pediatrician in the southwest suburbs with many Mexican-American children who have poor eating habits, addiction to electronic devices, not unlike most children in our society, minimal school physical education time, and fewer sports programs. The questioner says that this answer may lay more along the lines of political will versus health, but he's very interested in your comments around this.
Yes, yes, and yes. That's what I will say. You know, you hit the nail on the head. And what I will say is that, yes, education about exercise, healthy living, you know, nutrition needs to start early. And actually, I have seen this now in even schools. So, you know, full disclosure, I have a 4-year-old who is now in school and he comes home telling me, is that a healthy choice? And I'm like, oh, wow. You know, so he's already getting that teaching, which I don't remember ever getting until I think maybe high school when I took a health class, you know, which is maybe aging me. So I do agree. And, you know, in the work that we have done in our church-based interventions in diabetes education, I have found that it's the abuelas, the grandmothers who are coming to my classes and they're like, oh, I'm gonna, you know, the stuff I'm learning about nutrition, I'm gonna make sure my daughter is learning about this and also my grandchildren, because they're drinking so much soda, they're doing this and that, but I'm gonna take this back and I want to change how we're eating at home. Or the mom who's talking about how she's going to change what she's doing at home based on what she was learning. So I actually think that family-based education is maybe even the way to go, that we're not just teaching the mom or the dad with diabetes or the grandmother or the grandfather with diabetes, but the whole family is involved. And I do agree. I think that getting that teaching early on, be it at home, be it at school, is critical, because that is a time where I think we're developing our healthy habits, hopefully.
Thanks, Dr. Begg. Dr. Begg, we're going to stick with you and shift gears a little bit and have you to talk about the issue of vaccines and the Latinx community, please.
Yes, very important. Let me just, I have a few slides. Again, I love pictures and graphs. I think, okay. So we've heard a lot about what's happening with the vaccine, some of the barriers, the challenges. So the Kaiser Foundation did a survey of Hispanics in the US, and 7 in 10 Hispanics adults say that they will get the COVID vaccine, and which I think is actually not that bad, and granted, here we have a breakdown from definitely get, probably get, definitely not get. But I would say that many people are actually interested in getting it. So that's, to me, is good news. It's not the 100% that we want, but I think it is good news. Let me see here. And then, so here, but then it's interesting. I always say we need to disaggregate the data. We can't just put all Hispanics in one group. They're of different ages, they're from different countries, they have different educational levels. So here, the Kaiser Family Foundation disaggregated it by age and then also actually profession. And interestingly enough, the vaccine hesitancy was actually mostly among the younger Hispanics, so 18 to 49, which is interesting, which, I think has implications for when we're seeing our patients or doing community work. Who do we need to start focusing on potentially? Hispanic adults, and here, again, the age is a little bit lower because we do know that the average age of Hispanics in the US is a little bit older, that maybe a little less hesitancy. And among essential workers, we also see this sort of disparate, right? This disparity in terms of who wants to sort of wait and see and will only get it when required. Only a quarter of essential workers are saying they'll get it as soon as possible. I would wonder who those essential workers are and what their age group is, and if there's some sort of crossover with the young Hispanics. So here, this is a map I actually pulled a couple of weeks ago, and I did look at it recently, and it's about the same. So what are we seeing here? And I always come back to this map of Chicago, right? Where are we seeing most of the Latinx people, the Hispanic population on the southwest side and the northwest side? But we're seeing that the folks who are getting the vaccination are mostly on the north side. And this data from, so 17% are Latino, that's the Department of, I think the Chicago Department of Public Health. I was just looking at the Illinois Department of Public Health just a few days ago, and only 7% of people vaccinated in Illinois are Hispanic. So huge disparity there. So, but I don't want to end on a negative note. I actually do think that there is something positive here. So, and actually, it's great that they have this figure. I do not like that title, because when I look at this, I say, wow, when we look at their own doctor, so who are Hispanic adults trusting for their information? Well, 80% of older Hispanic adults and the younger, 73%, trust their own doctor. And then after we have the CDC and the local health department, and then it keeps going and going. So I think this is a great opportunity for physicians to work with their patients, talk about the vaccine. What are the myths? What are the hesitations? Use the patient-centered approach, because I think many patients may have some hesitation, right? In terms of, again, trust in the healthcare system. Was the vaccine developed too quickly? We can address those. And hopefully once we address those concerns, people will be more likely to get the vaccine. Now, one can also say, well, you showed me another slide that Hispanics are less likely to have access to care, or maybe even a primary care physician. But we have to use these opportunities, I think, when we have a patient in the room with us. And what I will say, I actually think that the city and the state have done work to think about racial disparities and health equity in terms of testing, in terms of the vaccine rollout. So Dr. Ezike, who is our director of the Illinois Department of Public Health, she not only gave her daily news conference with the governor in English, but then also in Spanish, which was fantastic. It just normalized it, right? It provided information to communities who may be relying on the TV or YouTube, to watch what's happening in terms of COVID in their communities. And then Chicago has this COVID-19 Latinx response too, and actually a whole task force thinking about health equity. So I do think there's a lot of positive, there's positive momentum. And I think we need to keep that going in terms of now the vaccination. Great.
Great. Thank you so much, Dr. Beck. Dr. Johnson, you also have some information that you'd like to share with us regarding the vaccine and some community efforts.
Yeah. Thanks, Dr. Miller. So let me move forward in my slides, because I'll skip for right now talking about kids, and we'll move first to the vaccine. And COVID-19 has occupied an immense amount of time and energy for the Echo Chicago project. We actually have 4 projects that are operating. One that's focused on adults in COVID, another one that's focused on kids in COVID, a third that's focused specifically on helping skilled nursing facility and nursing homes to keep their population safe. We're actually working with over 200 sites of care across the state on how to do that through the magic of the Echo Chicago project. And we worked with schools across the entire state to help them begin to work on how to prepare for opening, working with teachers and superintendents. But tonight we'll move away from Echo Chicago, although COVID-19 has occupied, the vaccine has occupied a lot of time. And just remind you that there are 2 currently available vaccines, one by Pfizer and one by Mrna, with the goal of helping our bodies fight off that disease. And, there are several more that are on the way, and you've heard about them. The Oxford AstraZeneca, the Johnson & Johnson or Janssen, and even more that are coming along. The methodology for the 2 vaccines that are available is an mRNA vaccine. And I want to reassure everybody that mRNA vaccines are not brand new. They've been in development since 1989. They've been in human trials for over 10 years, and they've shown an excellent safety record. In fact, there's already, well, prior to COVID-19, there already was a vaccine that was approved for use, which was the Ebola vaccine, certainly addressing a critical and frightening epidemic that has been going on and off in Africa for many years. I also want to make sure that it's clear there's no virus in the mRNA vaccines. Now, the Johnson & Johnson, the Oxford, there is a virus in those, but it's not COVID. So it's not SARS-CoV-2 that's in those vaccine products, but rather an adenovirus. Adenovirus is a virus that, by and large, causes something similar to the common cold, can cause pneumonia, but by altering the adenovirus, you can reduce it so that it's really just used as a method for delivering pieces of the COVID virus, SARS-CoV-2, to the host in the same way that the current mRNA vaccines deliver it. And what happens with the mRNA vaccines is that it's injected, and the particles, the vaccine particles that are injected, bump into the host cells. And that bump leads them to fuse with the surface of the host cell, muscle cells by and large, to lead to release of the mRNA inside of it. And then the mRNA tells the host cell how to produce the spike protein that generates the immune response. So it's not delivery of the SARS-CoV-2 virus, but rather a piece of the genetic material of the SARS-CoV-2 virus that then leads to the production of the spike protein, and only the spike protein. And that mRNA that's delivered actually leaves the body within about 10 days. And after that 10 days, it's gone. But luckily, the immune response remains. And this mRNA doesn't do anything to your DNA. All it does is lead to the generation of an immune response that then can fight on behalf of your body if SARS-CoV-2 gets inside of you. And this is a picture of exactly what I described just now, that the mRNA is delivered. And with the current vaccines, it's delivered in a fat globule. And the reason why that fat globule is so important is because it protects the mRNA from being attacked until it gets into the host cell. Once it's in the host cell, that fat globule melts away, so to speak. The mRNA is exposed. It directs the body to produce the spike protein. And then that spike protein either goes to the surface of the cell or it gets released into the bloodstream. And then by doing that, it causes a robust immune response that protects you should you see the virus in the future. And how good is it? Well, it's 95% protection against getting sick from the virus. We don't actually know whether or not it completely protects you from ever getting SARS-CoV-2, but 95% of the time, it protects you against getting sick at all. And about 100% of the time, it keeps you from getting significantly ill. We think that it may protect as many as close to 75% of people from actually getting the virus, but that's early data right now. And so we'll say for right now, we don't exactly know. So there's still questions that remain with this vaccine. How long does it protect you? Does it work as well in immunocompromised people, people whose immune system doesn't work well, maybe because they have HIV, maybe because they have cancer and they're receiving drugs. We don't have data on its effectiveness yet in children younger than age 16. We do have data down to age 16 for the Pfizer vaccine, but not yet for the Mrna vaccine. Will it prevent infection in addition to disease? As I said, that's still a question. But as I mentioned, there's some data on that to suggest that the answer is yes, but not in everybody. And then, will the vaccine prevent spread of SARS-CoV-2 by people who are vaccinated and get infected anyways? And we just don't know right now. And until we have a little more data, we won't be able to answer that question. Side effects, of course, is always on the minds of everybody. And 80 to 90% of people who get the mRNA vaccine will develop at least one local symptom. Their arm gets sore, some redness, maybe some swelling at the injection site. 50 to 80% of people who get it will develop some fatigue or maybe a headache, muscle pain, joint pain, or fever. And so you can expect some symptoms from the vaccine, but the good news is those symptoms only last for a day or two. There's a little more likelihood of getting symptoms after the second dose than the first dose. And people who are older than 55 are less likely to get those kinds of reactions that I've cited. But again, those reactions only last for about 48 hours, and then they're gone. A small number of people have a significant allergic response. It's about 3 to 5 people per million doses. So it's pretty rare, and it's able to be managed by giving people an epi dose through an EpiPen, or just giving them some Benadryl in order to manage those symptoms. People who are pregnant or lactating, they can take the vaccine, but talk to your provider about that. There's no reason why lactation can't occur, so breastfeeding can occur. But for pregnancy, some people are recommending that you wait until you're out of the first trimester. But recognize that people who are pregnant are more likely to have a severe problem from SARS-CoV-2 and get COVID disease and end up in the hospital in an intensive care unit. So that's why getting the vaccine is a better idea than taking your chances. Now, millions of people now receive the vaccine, and they're being monitored for the side effects. And so far, we haven't seen anything that we didn't already expect. And how did we know what to expect? Well, it was because of the trials that were done before the vaccine received its emergency use approval. And in those trials, we saw the side effects that I've mentioned. And so far, we haven't seen anything that was unexpected. But monitoring's still going on. But if this is like other vaccines that have come out, we're not going to see anything new. We're just going to see the kind of side effects that have been reported to date. Now, there are questions that people have asked. Are SARS-CoV-2 vaccines safe? There's concern that it was developed and tested too quickly. But the truth is that the reason why it was developed and tested so quickly was because first, there was a lot of disease around. So it allowed us to be able to see the impact of the vaccine much faster for this vaccine than many others. The other was that things were done in parallel, not serially. Usually when a vaccine is developed, the vaccine is analyzed in animals, and then there's a wait. And then it moves into people, and then there's a wait. And then decisions are made about manufacturing in order to ramp it up. And that leads to a wait. All of this was done simultaneously. And thankfully, the outcome of that simultaneous process was that it was safe, It worked. There was the money to develop manufacturing, and then the product came out very quickly. You know, people have asked, is there some kind of like microchip or nanotransducer in the vaccine? And the answer is unequivocally, no, there isn't. Are there severe side effects? Well, you've heard about them, so you can judge that for yourself. But remember, not only does COVID kill people, and the vaccine hasn't, but around 10 to 30% of people who get COVID disease are what come under that header of long hauler. People who have chronic symptoms and chronic complaints for literally months. The vaccine, 48 to 72 hours, and people are better. Will people die as a result of the negative side effects? No, they haven't. And now, I mean, I made this slide when we were up to just 450,000 people in the US had died from COVID. But now it's more. And no one has died from the vaccine so far. And then, will it alter your DNA? Well, no, because this mRNA, it can't even get near your DNA. It can't get into the nucleus of the host cell. And then it's all gone by 10 to 14 days. And then the last question that a lot of people have asked, is there a vaccine for white people and one for everyone else? And the answer is, there's only vaccines for people. So I'm going to hold off on talking about vaccine hesitancy since Dr. Big did such a great job around that, and give a chance to probably answer some of your questions and turn things back over to Dr. Miller.
Great, thank you so much, Dr. Johnson. We actually have quite a few questions that are in the chat box, and so I'm going to give some of them to you, and also Dr. Begg gives some of them to you as well. So let's start off with Dr. Begg, first of all. Dr. Begg, we have a question in the chat box that talks about the way in which people are getting signed up to get the vaccine. And so Walgreens website, CVS website, ZocDoc being kind of the Uber website for signups, and that this is being encouraged by our Chicago Department of Public Health. The questioner says that this requires a significant amount of digital ability in order to do that. And the questioner wonders, is this going to be something that's going to accelerate the disparities that we see in access to the vaccine?
Great question. And honestly, it probably already has accelerated the disparities that we're seeing. We're already seeing that more non-Hispanic whites have received the vaccine. Now, that could be due to being healthcare workers. I don't know. It could be, just the North Side. That's where people live. I'm not sure, but I think we're already seeing it. I know some health systems, including at the University of Chicago, we not only send messages through our portal, which is our medical record, how we communicate with our patients electronically, but we send text messages and we call. So we're doing all three. And I think that we have had a very thoughtful approach to how we want to approach our patients. Now, what about the folks who are not within a health system and are trying to find the vaccine on their own? Yes, these are challenges. I think that not only do you need to have a device, you need to know what site to go to. You need to be able to navigate that site. So you need to have English language capabilities, or I think some sites are in Spanish, but maybe only to a certain point. And then the frustration of going to the site, entering all the information only to find that there's no available sites, and then having to recheck that website. And they say that they've replenished the appointments, some of them hourly. Well, that's a challenge, right, for people who are working to be checking online. And then just access to Wi-Fi and internet. We do know that people of color, I think, have higher rates of smartphones versus like laptops and computers at home. So that's good. But again, I think that the person who's asking the question, I mean, this is an issue. And I think we need to find other ways to get the word out. And I know that the state and the city are thinking about actually having like fixed sites. I was just talking to some community members this morning, like in Little Village, where people can actually like come to a physical place to get the vaccine instead of into the ether and trying to sign up through some web-based format.
Thanks. Dr. Johnson, any comment on this point?
Yeah, no, I agree with Dr. Beck. I mean, this is one of the problems that has to be solved. And there are many people working on it, and I think we'll have a solution sometime in March when vaccine supplies expand and some of these sites are set up. There is work going on right now by the city to identify mass vaccination locations where people would be able to drive in. You know, there's some discussion about using, for example, the White Sox ballpark, the Cubs ballpark, and those kind of locations. There's even some conversation going on about using the United Center in its parking lot so that people can just drive directly through without having to get out of their cars and take that kind of approach. Here at the university, there is phone calling that's going on in order to try and expand access. And we're trying to figure out, are there other ways to reach out that won't involve the use of computer and technology. So I think those solutions are going to come, but in the meantime, this is a pretty serious problem and it needs a better solution.
I have another question that's come up that actually doesn't have anything to do with the vaccine, but has to do with some of the public health guidelines around prevention, and specifically around minority communities. The question is, how important is it for the various minority communities to understand and adhere to masks and social distancing? So Dr. Johnson, I'll start with you and then go to Dr. Beck.
Yeah, it's every bit as important, if not more so. You know, when we look at communities of color in the United States, what we find is that there is greater crowding in housing. People are essential employees more so. And what I mean by that is that they are required to come into work and they're more likely to have jobs that bring them face to face with large portions of the public. As a consequence, they're even more likely to be placed into positions where they're going to come into contact with somebody who has SARS-CoV-2 and COVID disease. As a consequence, they're more likely to be exposed. That means then that when they go home, because crowding is a higher problem, they're more likely then to come into contact with a larger number of people. That means then that the steps that are needed to prevent transmission of SARS-CoV-2 is even more important. That means then the use of mitigation. And what are those mitigations? Well, Dr. Miller already mentioned some of those, right? About, and the questionnaire mentioned some of those. Wearing a mask, protecting your eyes, in all honesty, is also important. So if you're going to have contact with the public, wearing some type of goggle or a face shield in addition to a mask will provide you with additional protection. Asking people who you come into contact with to wear a mask as well, if you have the ability to be able to do that and if your job and position will allow you. Hand washing, using the alcohol gels in order to protect yourself so that if you're touching a doorknob or a surface that others have touched, to wash your hands before you bring your hands to your mouth. So before you eat, before you bring your hands to your eye. I would say as a provider, I wash my hands easily 30 to 40 times a day because I'm walking in and out of rooms, I'm touching doors, I'm opening doors. And so it's very important to have access to that. And you can carry that in your pocket and replenish it on a daily basis. So that way you're able to do that degree of hand washing. Put that kind of pump on the surface by you, on a desktop or whatever it is. And then, of course, making sure that you're trying to stay away from people. And what I mean by that is that physical distancing. You know, I don't believe in social distancing, right? We need that to maintain our mental health. But physical distancing, that 6-foot distance, is something that often you have control over. And so these are some of the very important things. In a household setting, run the fan. If you've got central heat, just keep the fan running because you're changing over the air in that room. Crack the window in order to bring in fresh air. Now, I know it's cold outside. You don't have to open it wide. Just get a little bit of fresh air in there if you can. And turn up your heat a bit. So that way you can try and keep the room warm enough. Put on that sweater, but you're bringing in some additional fresh air because we know that if you can replace the air in a room, then you reduce the amount of droplet particles that lead to spread of COVID. And these are all little things that you can do to reduce your risk. And they work. And that's why it's important for all of us to remember that. And the last thing I'll say on this topic is what people are referring to as cohorting or pod formation. Reduce the number of people that are coming into your house. Keep it only the people that live there. That way, you don't have to worry about somebody, unbeknownst to them, bringing COVID into your home.
Thanks, Dr. Johnson. A question actually back to you, Dr. Johnson, and this has to do with the vaccine in children. I think that you got to this a little bit in terms of the information you presented on where the vaccine had been tested. But the question is, why can't children get the vaccine yet? And when will the vaccine be available for children?
That's a great question. And as a pediatrician, you know, I'm wondering the same thing. And there's good news there. The first is that the Pfizer trials down to age 12 are now complete. The data is being analyzed, and I expect we'll hear about that data sometime in April, maybe March, but probably more likely April. Mrna, they're enrolling right now. Johnson & Johnson, the Janssen vaccine, that one has also started to enroll. And Oxford Zeneca is looking to do the same thing. So I suspect that we'll have a pediatric vaccine sometime over the summer that will be available. Now, you know, later, I think we're going to talk a little bit more about kids and COVID. And the good news for us is that kids don't anywhere near as frequently get sick from COVID or get hospitalized from COVID as adults do. So I'm glad that we prioritized adults because I think that that was the right thing to do. But eventually, I want kids to get vaccinated too, because there is a small number of kids who get sick from COVID. But you know, I'm just going to use this as an opportunity to mention one other thing. And it's a little off topic, but influenza. Influenza is a much bigger problem for kids than COVID-19. And so it is vital that kids get their influenza vaccine every year. Every year, hundreds of children die, but maybe just as important, thousands of children end up in the hospital from influenza, way more than what's happening with COVID-19. So I hope that those of you who are listening tonight not only are worried about the COVID vaccine for kids, but also making sure that kids are getting their influenza vaccine every year.
Very important. I know that on the adult side, we're not seeing much influenza this season, but it's also because people, fortunately, are doing what they're supposed to in terms of wearing masks. And so the transmission is certainly less. Dr. Beck, a question for you. If you've already been vaccinated for COVID-19 and you're exposed to somebody who's positive, do you need to quarantine?
I think that we have evolving guidance on this right now. I think it's maybe a little bit different for healthcare workers than it is the public. And maybe Dr. Johnson may be best as he's an infectious disease doctor to talk about this. But I know that at the University of Chicago for healthcare workers, if we are exposed, we don't necessarily need to quarantine. But if we develop symptoms or 5 to 7 days after the exposure, we can get tested. And there's some also new travel guidelines out from the CDC as well. So the vaccine is effective again if you are exposed to someone, but maybe I'll let Dr. Johnson speak a little bit more to this as well.
Yeah, this is, you said it beautifully, right? This is an evolving area. And what we recently had was a change in the recommendations from the CDC. In fact, it came out just last week. And that recommendation was that if you've had, in the case of Moderna and Pfizer, if you've had both doses of the vaccine and you're 2 weeks after that second dose, then you have such a high likelihood of having had an immune response to the vaccine. After all, 95% efficacy. That the CDC has said that for at least 90 days after that, you don't have to quarantine if you've been exposed. You do have to wear a mask. You do have to be careful about keeping distance. So really observe that 6-foot distance. But as long as you do those things, you don't have to quarantine. In fact, you're being treated as if you had COVID-19, because we know that people who've had COVID-19 for 90 days after you're out of your infectious period, which is 10 days after your symptoms developed or 10 days after you were tested positive, that for at least 90 days, you are protected from getting COVID again, overwhelmingly so that you don't have to quarantine if you were exposed again. So we're treating people who've gotten the vaccine the same way we would treat somebody who had COVID-19. Now that 90 days is based on data for those people who have gotten COVID-19, where we're assured that your immune response is sustained. It's probably actually sustained for even longer, 5, 6, and maybe even 9 months. For the vaccine, we don't know how long that vaccine is going to be good for. We know from some preliminary data that it's good for at least 90 days. And in fact, there's even a little bit of data suggesting that it's probably good for 5 to 6 months, similar to what happens with people who get SARS-CoV-2 and COVID disease. So probably it's going to expand even further the duration where you won't have to quarantine. But for right now, 90 days. 90 days after you've gotten that second dose and you're at least 2 weeks out after that second dose. 90 days, you don't have to quarantine. It's a great question.
Great, thank you. Another question, and this has to do with kind of a dose response around getting the infection and being reinfected. If someone tested positive for COVID with minimal symptoms, does that person get some degree of immunity, or is the risk of getting reinfected the same as a person who never had COVID? So basically, if you get a little bit of COVID, are you going to have at least some immunity versus not ever having it at all and worry about reinfections? So Dr. Beck, I'm going to go to you first, and then after that, Dr. Johnson.
Sure. Well, the way I see it is you either have COVID or you don't. So if you've had COVID, you're lucky if you had either no symptoms or minimal symptoms, but you've had COVID. Now, from what we know, that 90-day period after getting that infection, you probably have some immunity, natural immunity, let's say. The thought is that that probably wanes with time. So can you get COVID within those 90 days? Probably not. After that, maybe. I think that's the best guidance that we have. That's why we're still telling people, even if you've had COVID, you can still get the vaccination. Just maybe wait 90 days after the time of the infection. We are seeing people who do get reinfected I was rounding at the hospital with adult patients, and we saw that there's been case reports around the country, around the world about reinfection. There's new variants out now also, which is also complicating this answer and the field of what's happening with COVID. So again, we're learning a lot more. We do think that 90 days after, within those 90 days, you probably have natural immunity. You probably will not contract COVID again. But again, there are these new variants out, and we have seen rates of reinfection. I'll let Dr. Johnson add to that.
Yeah, your chance within that 90 days of getting COVID a second time appears to be about 0.005%. I mean, that's really small. And that's why we're saying within that 90 days, you don't have to worry. But of course, Dr. Beck is correct. You know, this is still a moving target because viruses evolve. And so it is possible that we will get a variant in the US, similar to what's happened in some other parts of the world, where people early in the epidemic who got the version of SARS-CoV-2 at that time are not going to be immune. But so far, that 90-day window is really holding up. And so if it's within that 90 days, you get a get out of jail free card, right? You're okay. But beyond that 90 days, we're less certain about it. That's why we're also telling people wait 90 days after you got SARS-CoV-2 before getting the vaccine. It's not because we think the vaccine is going to harm you if you get it. It's because there's not enough vaccine to go around yet. And you're protected for that 90 days. So we want somebody else to be protected in that window of time too. And that's why we're telling people, hold off for that 90 days, let someone else get the vaccine. And then after that 90 days, go ahead and get the vaccine. And I'll tell you, 90 days from now, there's going to be a lot of vaccines circulating. So we expect it'll be way easier for people to get the vaccine by then.
Thanks for that comment, Dr. Johnson. I've got a question here for you, Dr. Beck, and this is based on the charts that you showed from the Kaiser Family Foundation. It says that the vaccine tracking project indicates that the Hispanic age gap and confidence in the vaccine, so over 50 being more likely to get the vaccine versus not. How do you explain the hesitancy in the younger population for those graphs that you showed us?
That's a great question. I think that there's probably a lot of conjecture around why that is. I think maybe looking at older Hispanics, maybe they are first generation. And I think that their perception and how they interact with physicians may be different, having maybe more trust in the physician and the healthcare system. That's how I explain it, right? That maybe if their doctor talks about it, they have a trust in their doctor. Whereas I think maybe the younger generation is more questioning, which is good, critical. I think maybe they want to participate in more shared decision-making around vaccinations versus just sort of taking what is told to them and what they're hearing on the news and through the government and such. So I think it maybe comes down to generational differences in trust of the healthcare system and interactions with providers. That's the one explanation I would give.
Thanks. Dr. Johnson, any comment?
Yeah, actually, I have a slide on this that I think will help, if you don't mind if I pull it up.
Please.
So let me just get it. There you go. So here are reasons why Americans have said that they will get the vaccine. And first and foremost, I want to protect my family. And by the way, the difference in color there represents what people answered in May versus December. There's not big changes there. This is data that was generated by NORC, which is an organization actually started at the University of Chicago to do survey work. So I want to protect my family. I want to protect myself. It's the best way to avoid getting seriously ill. I want to protect my community. Life won't go back to normal. It would allow me to feel safe around others. Well, when you read those and you think about age in relationship to those, people who are older, they have families. They're thinking about their community more than often younger people are. They're more worried about getting seriously ill because we know that the older you get, the more likely you are to get sick. And in fact, if you look at the demographics around who's going to get vaccinated and who's not, it rises in all populations as people are aging. So that older individuals are much more likely to want to get vaccinated than younger people. And then even if you look down at some of the lower things, my doctor recommends the vaccine. You know, people in that age group of 18 to 30, they don't have doctors. It's older people that have doctors. And so they're more likely to believe and receive that recommendation to get vaccinated. And then even last but not least, a chronic health condition, even there, that's something which we don't see in younger people, which is much more common in older individuals. So all of that contributes to why it is that the older people are more likely to get vaccinated than the younger people.
I know that certainly confirms my clinical experience with my patients. Most of the patients that I care for are over the age of 45. And I must say for people that are between 45 and 70, there are more questions and some doubt, and probably the break is actually a little bit earlier than that, around age 65. My patients who are over 70 have been calling me and saying, when can I get the vaccine? Or I've gotten a call to get the vaccine. What do you think about it? And so the issue that you brought up of having advice from a trusted messenger, such as a healthcare provider or a doctor, I know certainly is very reflective of the experience that I've had in my practice. Very important point. Got a few other questions here. There's a lot of talk about people abusing the system to obtain a vaccine prior to the grouping that they belong to. How is that being mitigated or guards? And I think that this is a little bit of a growth of the digital divide question, but that people are, I know for the Kenosha, Wisconsin, that they've actually stopped people coming from across the border from Illinois in order to get the vaccine because people are searching to try to get it wherever they can. So Dr. Johnson, start with you and then go to Dr. Beck.
Yeah, I think that's always on the minds of all of us. But the truth is that most people are honest. Most people follow the rules. If they know the rules, they'll follow them. So there's a small percentage of people that are doing that. And, efforts to try and weed that out. You've already heard what Dr. Miller mentioned. And part of the reason why many places are using the electronic medical record to reach out to people is because they have a bit more control over who they're reaching. And as a consequence, they are able to control that a bit better. But you've already seen some of the consequences. You've heard about that tonight of the problem with doing that. I'd rather take the risk of a few people abusing the system and just accept that, because I think we'll do a lot more good by opening up our systems to deal with the issues of technology and the lack of access through that. So I got to be honest, I'm less concerned about that and therefore much more concerned about this issue of making sure that we broaden who has access.
Thanks. Dr. Beck?
Yeah, thank you. Great question. And I agree with Dr. Johnson. I think it's probably a few people who are skipping the line, or I don't know what they're doing. They're finding the hack in the website. And that gets a lot of attention in the news. But again, being at the University of Chicago, being in the same primary care practice as Dr. Miller, I have seen many of my patients, we have our guidelines and how we're distributing the vaccine, and it works. My patients are getting their invites. It's systematic. So I think the system is working to a point. And I don't think it's these individual people who are abusing the system. I think we need to think more systematically. What are the systems and the infrastructures that we have in place that are impacting this disparity in who's getting the vaccine? And I think that there's lots of people thinking about it, the state's thinking about it, the city's thinking about it in terms of having mass vaccination events and sites. So again, I think I'm less concerned, but more thinking about sort of what are the systemic and the infrastructural issues that we need to deal with.
Very important point. We also need to track and to do a comparison between the communities where people live versus the communities where people are getting the vaccine to see if there are mismatches in that area. And it's something that we actually talked a little bit about during our first session in the series. I'm going to take one more question, and then after that, I'm going to bring Dean Osborne in. The question is, do you have a concern that with the 7 variants identified, which were not in the initial mRNA vaccine development, now in the US, if we vaccinate, we'll select to drive these variants, especially because we're lacking in genomic surveillance? So the question is, are the vaccines that are being developed appropriate for the different variants that we're seeing? Dr. Johnson?
Yeah, that's a great question. And of course, I'm going to give you an answer that won't be entirely satisfying. I mean, this is what viruses do. That's what evolution is all about, is that they are potent evolutionary machines. When we think about this and we think about the number of people in the world, and we recognize that we evolve, but very, very slowly. I mean, there's 7 to 8 billion people in the world, and we've evolved, right? There are that many viruses in each person. So they just evolve very quickly and they're responding to their environment. What we always hope is that they have some essential part that we recognize and exploit in terms of generating a vaccine or the immune response. But, we don't know yet what part of SARS-CoV-2 will allow us to do that. So you're right. It's going to keep evolving. And maybe we will get the vaccine out fast enough that the virus will not mutate enough to escape the current versions of the vaccine. But I think the odds of that are relatively small. And that's why already, for example, Pfizer and Mrna are working on new variations. That's part of the beauty of the mRNA vaccine platform, is that you can just put a different mRNA in there and expand the capacity. So if I had to predict the future, I think what will happen is we'll vaccinate a ton of people. SARS-CoV-2 will respond to that. In a year from now, there'll be a new version of the virus starting to circulate, but we'll have a new version of the vaccine by then. And so just like needing to vaccinate people against influenza every year, we're probably going to have to immunize people against SARS-CoV-2 every year or every other year, something along that line. But so far, we're staying ahead of it. The vaccine may not be quite as effective against some of the variants that have been identified, but so far it works against all the variants that have been seen. And hopefully we can just keep doing that and slow down the pace at which the virus evolves, so that way we can stay ahead of it. I'm optimistic that we'll be able to do that, but only time will tell.
Well, thank you so much for that comment. I'm going to bring in Dean Osborne at this point because I think that she may have a few questions for our panelists this evening.
I do. I'm so delighted that both of you were here. And I think we have time. I will ask each of you one question and then we will conclude, and I'll pull up some slides to remind people to register for the next event. But well, I'll ask both of my questions at once, but they're directed to each of you. Dr. Johnson, you ended with optimism, that you're optimistic about the capacities of vaccines. So one question I do have for you is if you could talk a bit more about other vaccines that are in the pipeline, particularly ones like Johnson & Johnson that are using different kinds of technology or cell biology. And if you could say a little bit about your confidence and optimism or about them. And then Dr. Begg, along the lines of optimism too, I'm a historian. So when people ask me about the future, I say, no, I can tell you about the past and what insight that might give for the future. But so I'm going to turn the future question on you. And that is, everyone wants to know, everyone is trying to plan. What do you think we can expect in the fall, in a year from now, in 5 years from now? You know, is it going to be a world of a new normal, or will in 5 years we will be back to normal? So I know that that's a big one, but. So Dr. Johnson, do you want to start with, we'll give Dr. Begg a little time to mull it.
Okay. Well, so right now we have the mRNA vaccines, and what's coming are the adenoviral vector vaccines. And you can almost think of them in the same way you think of the RNA vaccines, except that we're using a different delivery mechanism. And it's the royal we, I'm not working on those vaccines. We're using a different delivery mechanism. Instead of using we'll say a fat globule, what we're using is an adenovirus. The adenovirus has been attenuated. What that means is that it's been weakened to the point to where it doesn't make you sick. Or we're using another animal adenovirus, a chimpanzee adenovirus, and that adenovirus can get into the host cell, but it can't replicate in the host cell. And as a result, it's not going to make you sick, but it can be used as a delivery mechanism to deliver that messenger RNA to do the work that we want to have the host do, which is to produce that spike protein. Now, why do we need a different mechanism? And the reason is because it's a more stable vaccine. You know, one of the big problems with the mRNA vaccines is that they either have to be super cooled or super duper cooled. I mean, the Pfizer vaccine has to be held at -80. The Mrna vaccine needs to be held at -20. I mean, those of us in winter here know what that experience is like. That's pretty cold, right? And the problem is that when that vaccine warms up, well, it only has a very short shelf life. That makes it really complicated to move around. Like the Pfizer vaccine, there are only 13 sites in the city of Chicago that can handle that vaccine. There are about 400 sites that can handle the Mrna vaccine. But there would be thousands of sites that can handle the adenoviral vector-based vaccines that are coming. The Oxford Zeneca and the Johnson & Johnson Janssen vaccine. So that's the beauty of those vaccines, is that they could be handled at your corner doctor's office instead of having to go to these special locations for the Mrna or the Pfizer. Now, are we losing anything by using an adenoviral vector? Well, the answer is maybe. They're not quite as efficacious, it appears, although we don't know that 100% yet. But because you can get it delivered in so many other ways, it means you can reach a much larger population. And this is particularly important, in fact, outside the United States, even more so than inside the United States. So we need these different vaccines for those reasons. And maybe they'll work as well. They certainly will work as well against severe disease. They don't seem to work quite as well yet against more mild disease. But that's okay, because we can keep people healthy. Maybe it'll just be the common cold that people get. That's a nuisance and annoying, but at least people aren't going to die. And maybe people won't get chronic disease from them. And so that's why when those come out, those are going to be important to use, and hopefully people will have access to them. So I hope that answers the question, Dean Osborne.
Thank you. Dr. Beck.
Yeah, that was a
Okay,
great.
sure.
Sure. So I think that, yes, I think our world, our life has changed. I think as a mom, sending my kid to school, that is different. It's going to be different. You know, I think that now we're probably going to be keeping kids home if they have the sniffles, because we don't know if it's COVID or not until they get vaccinated. I think maybe we need to start testing children either at school through the school nurse or at home. I think those are going to be evolving things that we may see when the technology is there. I think there's going to be those protections at school. I think in terms of healthcare, virtual visits are here to stay. That has been one of the things that has been expedited, I think, through the pandemic, but it's also allowed us to provide care to patients who have transportation issues or, you know, are at home or feeling ill. Why are we bringing them into the hospital or to the clinic? Let's provide care virtually. I think in terms of research, it has changed research as well. I don't give conferences. I'm not traveling and giving conferences. I'm able to give a talk on the other side of the world virtually, which is fantastic, or attend or hear what people are doing. Even, you know, the diabetes group visit work that I'm doing, we switched over to virtual diabetes group visits. So now we're providing care to people with chronic illnesses, providing social support in a virtual world, which is fantastic. So I think that some things are here to stay. And I think we'll see the evolution as we see vaccines in children, what's happening in schools and in clinics.
Dr. Miller, do you want to have a last word?
Just a last word of thanks to my colleagues, Dr. Daniel Johnson and Dr. Ishia Beck, for joining us this evening on this for this discussion. Also to thank our listeners and viewers for the roundtable this evening. You asked lots of great questions. I'm sorry that we couldn't get to all of the questions that were in the chat, but certainly you'll hopefully, as you read more and more and see more and more about the COVID-19 pandemic, you'll be able to learn more. I think one of my takeaways from this evening is that the word evolution and in progress, I think, are probably some of the key phrases that come from this, and that we're just going to need to be mindful and watchful as time goes on. Dean Osborne?
I also want to thank all of our panelists, Dr. Begg and Dr. Johnson and Dr. Miller. It's such a pleasure to work with you on this series. And as the screen, I hope I successfully shared it. You see, please, I remind you to please register in the audience for next week. And I thank our audience for coming. It's really wonderful to have you here and to learn from you and to hear from you and to hear your questions. And just if you're interested in more free accessible events, Dr. Fauci is coming to Harris pretty soon and will be interviewed by the dean there. We have some sample discussions at Graham School for you if you want to find out more about what we do at Graham. And I think that brings us to thank you. Thank you all.